Welcome everyone. In this video we shall be talking about acromegaly and discuss all the questions regarding acromegaly. So moving on to the first question, which of the following mechanisms can lead to acromegaly? Ectopic GHRH secretion from bronchial carcinoid. Yes, this would cause, because ectopic GHRH will lead to increased growth hormone and it will be unregulated. So this will cause acromegaly. Ectopic growth hormone secretion from pancreatic tumor, again it will cause acromegaly because the ectopic growth hormone is again unregulated. Hypothalamic GHRH hyperplasia. Yes, this increases growth hormone releasing hormone, which will lead to increase in growth hormone, and this might cause acromegaly, but it is a very rare cause of acromegaly, right? It's usually not seen in a GHRH hyperplasia, right? And pituitary acidophilic adenoma, yes, of course this will cause. This is rather the most common cause of acromegaly, accounting for around 95% of the causes, right? So our answer should be A, B, C and D. Although if examiner doesn't consider C as the correct answer, then our answer would be A, B and D. C is a very rare cause. Over here we will answer option D as a correct option, but option B could have also been an answer, right? It all depends upon the examiner. Moving on to the next question, right? This is a match the following type of question, right? So stimulates growth hormone release. Growth hormone releasing hormone stimulates growth hormone release. Then inhibits growth hormone release. Inhibits growth hormone release. It is somatostatin. Yes. Acts via JAK-STAT pathway. Growth hormone acts via JAK-STAT pathway. And besides growth hormone, we have prolactin. We got erythropoietin, and we got leptin, which also acts via JAK-STAT pathway. Okay. And mediates tissue growth factors. It is by the somatomedins, which is IGF-1. So the answer should be 1A, 2B, 3C, 4D. 1A, 2B, 3C, 4D, option A. Okay. Moving on to the next question. So a 36-year-old woman presents with increasing shoe and ring size over 2 years, coarse in facial features and oily skin. Which of the following symptoms would most likely precede these findings? Now the clinical features suggests a diagnosis of acromegaly. The clinical features suggest of acromegaly over here. Which of the following symptoms would likely precede? Remember that the clinical features of acromegaly appear in a specific sequence. So what is the sequence of clinical features in acromegaly? Right, we will be dividing into three types. Number one are the early features. Early features are our endocrine features. Right, our endocrine features. What are the endocrine features? It is amenorrhea or galactorrhea. Amenorrhea or galactorrhea. Okay. Then after early features, we get the intermediate features. Under intermediate features, we get the metabolic changes. Under metabolic changes, we have diabetes mellitus, we get hypercalcemia, we have hyperphosphatemia, right? Besides the metabolic changes, we have the soft tissue changes. Under soft tissue changes, we get a lot of things, right? Like macroglossia, like OSAS, obstructive sleep apnea syndrome, all those things. Even entrapment neuropathies like carpal tunnel syndrome, right? And the skin changes as well. And after intermediate, we have the late changes. Under late changes, we have the skeletal changes. We have skeletal changes like jaw prognathism, right? Increased limb size, increased head size, right? Those things. And also the visual field defects. Visual field defect is also a late feature. So over here, the question symptom would likely precede these findings, right? Precede means which is an early change, right? Amenorrhea, yes, it is an early change. Visual field defect, no, it is a late change. Jaw prognathism, late change. Arthralgia, intermediate to late change. So our answer should be A. Okay. Moving on to the next question. A 38-year-old man presents with increased shoe size, frontal bossing, coarse facial features and oily skin. What is the most likely additional finding? Again, from the clinical features, we can make a diagnosis of acromegaly. Okay. So what is the most likely additional finding? Decreased jaw size? No, there would be increased jaw size in acromegaly. Increased interdental spacing? Yes, the space between two teeth. That's the correct answer. Hypoglycemia? No. Over metabolic changes, increased growth hormone will lead to insulin resistance. So increased growth hormone leads to insulin resistance, right? And insulin resistance would rather increase glucose, right? So there would be hyperglycemia. And decreased libido due to hypergonadism, no, this is a false statement. There would be decreased libido. There would be decreased libido, but that would be due to hypogonadism. Right, hypogonadism in acromegaly can be due to two reasons. Hypogonadism in acromegaly can be two reasons. It can be due to an associated prolactinemia, associated hyperprolactinemia, associated high prolactin levels, or it can be secondary to macroadenoma. The macroadenoma can compress the pituitary stalk, and that would decrease the gonadotropins. Right? That would lead to hypogonadism. Okay. So over here, our answer would be B, increased interdental spacing. Okay. Moving on to the next question. Identify the most likely. Just a second. Identify the most likely diagnosis. Right. Over here we can see coarse facial features. You can see the coarse facial features. Right. We have thickened lips. We got thickened lips in this feature. We can see over here frontal bossing. We can see frontal bossing. We get an enlarged nose. Over here. We also have prognathism. Prognathism. We also have prognathism. Right, every feature is suggestive of acromegaly, and besides that, this is a very well-renowned image, right? Everyone knows that this is a picture of acromegaly, right? Moving on to the next question. Now, talking about the systemic manifestations of acromegaly. Diabetes mellitus. Yes, diabetes mellitus is seen in acromegaly. This is due to increased growth hormone causing insulin resistance. Right? Hypertension. We do get hypertension in acromegaly. This is due to increase in aldosterone. What does aldosterone do? It increases sodium and water reabsorption. Okay. Next, cardiomyopathy. We do get cardiomyopathy. We get a hypertrophic cardiomyopathy, which is an asymmetrical left ventricular hypertrophy. Right, that can progress to heart failure. CAD, arrhythmias, right? Rather this hypertrophic cardiomyopathy is rather the most common cause of death in acromegaly. Osteoporosis. If we talk about osteoporosis, no, we don't get osteoporosis. Rather, we get increase in bone mass. Or rather increase in bone turnover, right? Why is it so? Because of increased production of 1-alpha hydroxylase. 1-alpha hydroxylase by the tumor. 1-alpha hydroxylase. So this would result in increase in vitamin D3. That would result in increased absorption of calcium and phosphate. Right. That would result in increased bone mass. Okay, that results in increased limb size, rather the skeletal changes. So osteoporosis is the wrong option. So A, B and C, option C should be correct. Now besides these changes, we also have other clinical features that are associated, like excuse me. Under respiratory features, we can have OSAS, obstructive sleep apnea syndrome, that can progress to pulmonary hypertension, right? Besides that, in GIT, we can have colonic polyposis, right? We can have goiter in thyroid. This is due to increased IGF-1 mediated growth. I'm so sorry. Right. Besides that, we have the skin manifestation. Under skin manifestation, we have acanthosis nigricans. Acanthosis nigricans is due to insulin resistance. Besides that, we have seborrhea. Seborrhea causes oily skin. Besides that, we have hyperhidrosis. And we can also have entrapment neuropathy. Most commonly in the form of carpal tunnel syndrome, right? So these are the associated systemic features, that is systemic manifestation that we can get in acromegaly, right? Now we will be moving on to the next question. Here, a 35-year-old woman with acromegaly complains of numbness in hands, especially at night. So the symptom is due to brachial plexus compression. Brachial plexus compression would not result in symptoms of only hand. Your whole upper limb would be involved. Okay? Carpal tunnel syndrome, this is the most probable answer. Yes, in acromegaly we do get an association. Diabetic neuropathy, no. Diabetic neuropathy, we don't get diabetic neuropathy as an association to acromegaly. And again, peripheral vascular disease, no, not associated with acromegaly. Carpal tunnel syndrome is our best answer. Okay. Moving on to the next question. A 45-year-old man complains of headache, sweating, increased shoe size, hypertension, glucose intolerance. Right. Everything again suggests of acromegaly. Right. Which of the following is the mechanisms explains the insulin resistance? Decreased GLUT4 activity in skeletal muscles. This is a true statement. This is rather the definition of insulin resistance. Increased hepatic glucose uptake. No. If there is increased hepatic glucose uptake, why would there be glucose intolerance? Right. Upregulation of insulin receptors. This is just the opposite of insulin resistance. And increased insulin clearance. If there is increased insulin clearance, there would be glucose intolerance, there would be insulin resistance, but this is not seen in acromegaly. Increased insulin clearance is not a feature of acromegaly. So 8A should be our answer. Okay. Moving on to the next question. Which of the following changes are reversible after successful treatment of acromegaly? So remember that the reversible features are our early and intermediate clinical features, right? The late features are not reversible. These early and intermediate features are reversible. So what are they? They are the endocrine changes, they are the soft tissue changes, they are the metabolic changes which are reversible. Okay. So soft tissue swelling, yes, it is reversible. Bone enlargement, no, it is a late feature, right? Diabetes mellitus, again a metabolic change, so it is an intermediate feature, so it will be reversible. Sleep apnea, it is a soft tissue change, so it will be reversible. So A, C and D should be our answer, right? Moving on to the next question. Best single screening test in acromegaly. Just remember it as a fact that the screening test for acromegaly is serum IGF-1 levels, right? Serum IGF-1 levels is the screening test for acromegaly. Growth hormone suppression test is our confirmatory test. Is our confirmatory test. This is done via OGTT. MRI of pituitary is for localization of the lesion. Random growth hormone levels, it is not used because of the pulsatile nature. Of growth hormone, it is very unpredictable. That's why it is not used for diagnosis. Moving on to the next question. A patient with suspected acromegaly has a fasting growth hormone of 6 nanogram per ml. After 75 gram oral glucose load, the growth hormone is 5 nanogram per ml. This is the growth hormone suppression test. Normally when growth hormone suppression test is performed, after the 75 gram OGTT, your growth hormone should be less than 1 nanogram per ml. This is the normal value. If it is more than 1 nanogram per ml, then it is diagnostic of acromegaly. Okay? Here it is 5, so it is diagnostic of acromegaly. No. What is the interpretation? Normal response, no. Diagnostic of growth hormone deficiency, no. Suggestive of acromegaly is a screening test. Increased IGF-1 would be suggestive of acromegaly. Diagnostic of acromegaly, yes. So D should be our answer. Okay. Moving on to the next question. Excuse me. Which of the following lab abnormalities are often seen in acromegaly? Hyperglycemia, yes, this is due to increased growth hormone and insulin resistance. Hypercalciuria, yes. Increased bone turnover, there is increased 1-alpha hydroxylase production. Both of them leads to increased calcium, that is increased hypercalcemia. Increased hypercalcemia will lead to hypercalciuria. And this hypercalciuria is a risk factor for urinary stones. It is a risk factor for stone formation. Hyperphosphatemia, again same reason, increase in 1-alpha hydroxylase will lead to hyperphosphatemia. Hypokalemia, no, hypokalemia is not seen, right? Remember that growth hormone do not, growth hormone has no effect. Growth hormone has no effect on potassium. Although one might argue that growth hormone causes increase in aldosterone that will lead to loss of potassium and hypokalemia, but that loss of potassium ions are compensated. That's why we don't get hypokalemia. Overall, growth hormone has no effect on potassium. So our answer should be A, B and C. Option C should be our correct answer. Moving on to the next question. This is a match the following regarding the diagnostic test. Screening test is IGF-1. We have read that. And confirmatory test should be our growth hormone suppression. Oral glucose suppression test, yes. Fluctuating and not diagnostic, random growth hormone should be fluctuating, and MRI pituitary is localization. So our answer should be 1C, 2B, 3, 1C, 2A, 3B, 4D. 1C, 2A, yes, option D should be our correct answer. Right, we have discussed this, right? Moving on to the next question. What is the most likely diagnosis from this X-ray? We can see over here there is an enlarged cella. There is an enlarged cella turcica. Over here we can see hyperpneumatization of, there is hyperpneumatization of the frontal bone, hyperpneumatization of sinuses of the frontal sinus. Right, there is prognathism, and moreover there is overall thickened calvaria, right? There is thickened calvarium. Right? So all these features are again suggestive of acromegaly, a direct answer. Okay. Moving on to the next question. Which of the following images are seen in acromegaly? Imaging features seen in acromegaly. You get enlarged cella turcica. Yes, we do get. There is enlarged cella turcica. I'm so sorry. There is enlarged frontal sinus. Yes. There is prognathism. Yes. Loss of normal pituitary bright spot on MRI. Yes, we do get loss of normal pituitary bright spot on MRI. So our answer should be A, B, C and D. Option D should be our answer. Okay. Moving on to the next question. This radiological finding is most consistent with. Now this is known as the spade phalanx sign. Right, and this is very much characteristic of acromegaly. Okay. Moving on to the next question. A patient with coarse facial features presented with hoarseness of voice and arthralgia. An MRI brain was done which shows the following finding. What is the most likely visual field defect seen in this patient? Over here, right? Over here, the clinical features are suggestive of acromegaly, right? And this MRI shows, an enlarged pituitary gland, right? So this enlarged pituitary gland is gonna compress on optic chiasma, and optic chiasma compression can lead to bitemporal hemianopia. We know this. Right. If we talk about the other options, homonymous hemianopia will be seen in a lesion proximal to optic chiasma. Right. It is seen in the proximal lesions, more proximal lesions. Right. Central scotoma will be seen in optic neuritis. And quadrantonopia is seen when your Baum's loop or Meier's loop, are involved. Right. We shall be talking about them in some other videos. Right, and over here just remember the fact that enlarged pituitary gland compresses the optic chiasma, that would cause bitemporal hemianopia. Okay. Moving on to the next question. A 40-year-old woman with macroadenoma and bitemporal hemianopia diagnosed with acromegaly. What is the best initial treatment? Right. If we talk about the treatment protocol in acromegaly, if there is treatment protocol in acromegaly, the first treatment is surgery. It should be a transpenoidal surgical resection. Answer over here should be B, transpenoidal surgical resection. Now, if after surgery you get persistently increased IGF-1, or there is residual disease, or if there is a recurrence, right? A second choice should be somatostatin analogs, right, in the form of octreotide. Somatostatin analogs in the form of octreotide. Okay. Moving on to the next question, right? This is pharma integration. Right, match the following. Somatostatin analog, yes, octreotide is a somatostatin analog. If we talk about dopamine agonist, bromocriptine is a dopamine agonist as well as cabergoline. Okay. Then growth hormone receptor antagonist. Pegvisomant is a growth hormone receptor antagonist. Useful if prolactin co-secretion is present. Useful if prolactin co-secretion is present. Cabergoline is used. Bromocriptine can also be used. So over here there is a confusion regarding option 2 and 4 and B and D. Excuse me. Right. So 1 is A, 3 is C. We are confused regarding 2 and 4. Remember the fact that yes, although we can use bromocriptine for prolactin co-secretion, but the drug of choice is cabergoline, right? Bromocriptine will only be used in a pregnant lady, right? So cabergoline is a better choice for option D. Cabergoline is a better choice for option D. So we would mark 2 as B and 4 as D. Okay? Because cabergoline is the drug of choice. Bromocriptine will be used only in a pregnant lady. So our answer should be A, B, 1A, 2B, 3C and 4D. 1A, 2B, 3C and 4D. Okay? Although the other option was also present over here. 1A, 2D, 3C and 4B. That could have been an answer, but the better choice should be option D. Okay? Moving on to the next question. A patient with acromegaly continues to have an elevated IGF-1 after transperineal surgical resection. Right. So we have read that. Right. The next step should be octreotide. Right. Somatostatin analogs. Moving on to the next question. Post-treatment monitoring in acromegaly. Post-treatment monitoring in acromegaly includes periodic IGF-1 levels. Yes, it is rather the best marker. It is rather the best marker for long-term control. Okay. Growth hormone suppression test, we need to perform this, right? If this is negative, if the growth hormone suppression is not present, if the suppression is absent, this suggests of residual disease. Right? Yes, pituitary MRI has to be done annually. Yes, pituitary MRI has to be done annually. This is to rule out recurrence. Of the disease. Yes, acromegaly can have recurrence. And plasma cortisol level, it is not required. Plasma cortisol level would be required for Cushing and Cushing, Addison, for those diseases, right? So our answer should be A, B and C. Option C should be correct. Okay. Moving on to the next question. Leading cause of death in untreated acromegaly. It is hypertrophic cardiomyopathy. I have already read that there is concentric left ventricular hypertrophy. That would lead to a diastolic. That would lead to diastolic dysfunction, which will precipitate heart failure. Besides these, concentric hypertrophy can also lead to arrhythmias and CAD. Rather, arrhythmias are the cause of death. Rather, arrhythmias are the most common cause of death in hypertrophic cardiomyopathy. Okay. Moving on to the next question. Which malignancies are at an increased risk in acromegaly? We have read that in acromegaly there is colonic polyposis. Right. So there would be increased chances of colon carcinoma. Besides that, there is also goiter because of increased IGF-1 growth. Right. So that can also trigger thyroid carcinoma. But acromegaly does not affect your breast and pancreatic tissues. So our answer should be A and B. Okay. Moving on to the next question. A patient with acromegaloid features have normal growth hormone and IGF-1 levels. Okay. Which of the following conditions should be suspected? Acromegaloid features with normal growth hormone and IGF-1, you should suspect pseudoacromegaly. Right? Acromegaly clinical features are present, but your lab findings are normal. It is pseudoacromegaly. Now, pseudoacromegaly can be due to certain secondary causes, right? Like the insulin resistance syndromes, like the Lawrence-Moon-Bardet-Biedl syndrome, Beckwith-Wiedemann syndrome. Those things can be cause for pseudoacromegaly. Besides that, certain drugs can also cause, like minoxidil and phenytoin. Okay. So moving on to the next question. Features distinguishing gigantism from acromegaly. Gigantism is nothing but excess growth hormone in children. excess growth hormone in children. Okay. So age of onset before epiphyseal fusion, yes, this is a feature of gigantism. Normal body proportions, yes, normal body proportions are seen in gigantism, but not in acromegaly. Excessive height, yes, because the growth hormone excess is seen before epiphyseal fusion, so there would be increase in height. Increased IGF-1, it will be seen in both gigantism as well as acromegaly, so this is not a differentiating factor. So our answer should be A, B and C. Option A should be correct. So if we have a look at the difference between gigantism and acromegaly, the first thing is the age of onset. The first thing is the age of onset. This is before fusion, before epiphyseal fusion, right? And this is after fusion. And if we talk about the growth, there would be increased growth. There would be increased growth, but this would be proportionate. This would be a proportionate growth. This would be disproportionate. And there would be linear growth in gigantism. Increase in height would be present, whereas over here we would get acral and soft tissue growth, right? With this we come to the end of this discussion. If you like this video, consider subscribing to my channel, and thank you for watching.